Hi everyone, this is a quick medical genetics lecture by me, Philip Boone. This is a lecture about congenital adrenal hyperplasia. This is part one of two of a series. This is a reasonably complex disorder, so two videos are necessary. The first one being the basics of the disorder, specifically the most common variety of it, which is called 21-hydroxylase deficiency. The second video will go over the more minor forms of CAH, as well as some additional details. So in this lecture, I'll go over what the disorder looks like clinically, molecularly, how you make the diagnosis by laboratory tests, what the inheritance and prevalence of the disorder are, how you treat and manage the disorder, and then mention some references where you can learn more about congenital adrenal hyperplasia. So very briefly, clinically, I want to say that this is a disorder where aldosterone and cortisol levels are low. So low aldosterone, low cortisol. And testosterone level is high. That leads to, on account of these two abnormalities, adrenal insufficiency, and here we get virilization of females, meaning that the external genitalia look more male-like than you would expect. So that's the basic, the few sentence description. Before going into the details of the clinical picture, I want to talk about molecularly how the diagnosis happens. I think skipping ahead is necessary for an understanding so that we can then go back and see how the molecular abnormalities result in clinical phenotypes. So first, to understand CAH, let's look at something called the Hpa Axis, or hypothalamic pituitary adrenal axis. What this is a normal production of CRH, which is corticotropin releasing hormone, that stimulates, and this is coming from the hypothalamus, CRH stimulates ACTH, adrenocorticotropic hormone, to be made from the pituitary. ACTH then stimulates the adrenal gland. This is a kidney, the adrenal gland sitting on top of it. The adrenal gland makes cortisol and other hormones, and then cortisol feeds back and inhibits both CRH and ACTH. With any hormone cycle, this negative feedback is pretty characteristic. This is how it works in the case of the Hpa axis. Now imagine, as I had said, that in congenital adrenal hyperplasia, you're not making cortisol well. Therefore, you don't have this negative feedback. ACTH can increase. We get a whole lot more stimulation of the adrenal gland than we usually would, causing the gland to be or experience hyperplasia. It's of the adrenal gland, and this happens even before birth, so it's congenital. That's the whole name of the disorder, congenital adrenal hyperplasia. Most basically, this is how it works. So how is it that cortisol and also aldosterone are not made by the adrenal gland, and how does testosterone get made in excess? So the adrenal gland, I've shown very tiny there. Let's zoom in and take a look at it here. So this would be outside the adrenal gland, the most superficial layer, one layer deeper, and then a whole deeper section. These three layers make up the cortex, or the shell, and you can think with the cerebral cortex, it's the same thing, it's the outermost layer. The innermost layer is the medulla, which makes catecholamines, not the focus of this lecture, so just keep that in mind, but won't be involved in what I talk about from here on out. Within the cortex, there's three layers. We have GFR, so what do these stand for? So each of them start with the word zona, or zone. This is the zona glomerulosa, zona fasciculata, and zona reticularis. And going from outside to in, these are the three layers within the adrenal cortex. The whole point of what these layers do is they take cholesterol, then through a series of intermediates, make one hormone for each layer. In this layer, it's aldosterone that gets made. In this layer, it's cortisol. And in this layer, it's testosterone. There's a number of intermediates. There's a number of enzymes. I've only shown the most important ones. For the unimportant enzymes, I haven't even listed them. They're just shown by the arrow. For the unimportant intermediates, I've just put a star there. So the only important stuff for this lecture is that cholesterol comes in. Through a series of intermediates, we can make aldosterone, cortisol, and testosterone, unless this enzyme that's present at these two stages is deficient. This enzyme is 21-hydroxylase in both cases, And if that is not working as it should, because the gene that makes it is mutated, you don't get aldosterone and you don't get cortisol, and instead the intermediate just upstream backs up, the most important one of which is 17-hydroxyprogesterone. 17-hydroxyprogesterone gets shunted over this way, leading to increased testosterone. So decreased aldosterone, decreased cortisol, decreased testosterone. The mnemonic for remembering these layers is that aldosterone has to do with retaining salt, cortisol has to do with increasing your glucose concentration in times of stress, so sugar, and testosterone leads to secondary sexual characteristics, so salt, sugar, sex. And indeed, if we have abnormalities in the concentrations of these hormones, you can guess we're going to have problems with salt, problems with sugar, and problem with sexual characteristics. So let's go through more in depth for decreased aldosterone, decreased cortisol, and decreased testosterone. Indeed, what is the phenotype that results from these problems? So for decreased aldosterone, you get something called salt wasting. Normally aldosterone retains salt. If you don't have aldosterone, you waste salt. You can become hyponatremic, you can become dehydrated, babies will vomit, have shock, and might even die. And this is going to be something that happens early. And this is the most important reason that congenital adrenal hyperplasia is actually one of the disorders that's tested for in the newborn screen, in that salt wasting and death can happen within the first few days or weeks of life, so it's important to anticipate it with a positive result on the newborn screen. What else can happen? We can have increased potassium, as one of the results of aldosterone action is to get rid of potassium. The same thing with acid. We can get an acidosis if we don't have aldosterone. Let's move on to decreased cortisol. So what's the normal point? Is that we can use cortisol to increase our glucose concentration during times of stress. So if we don't have it, we can have hypoglycemia. And this is specifically because cortisol works on glycogenolysis. So if you don't have it, you don't break down glycogen into glucose when you should. And then, of course, with decreased cortisol, as I had already mentioned, you can have increased ACTH, which leads to hyperstimulation, hyperplasia of the adrenal glands, and you can also get a benign adrenal tumor as a result of that. Next, let's move on to increased testosterone. So this is the first case that we have where something different happens in genetic females versus genetic males. So in genetic females, we get virilization. And if you want to think about one word that's most characteristic of CAH, it would be virilization in females. What this is a maleness or complete maleness of their external genitalia. So something like an enlarged clitoris, a shallow vagina, ambiguous genitalia. We can have early pubic hair, we can have facial hair, or the most severe form would be a complete penis with an empty scrotum. And this would be a baby who would assume to be nothing wrong with them, it's just a male, who has undescended testes, as the scrotum would be empty. Only later on might you find out that in fact that female has congenital adrenal hyperplasia. Some of the things in females will present later on, for example, increased early growth and then a decreased eventual stature on account of increased bone age and early epiphyseal closure. You can also have menstrual irregularities or anovulation. Final thing that I want to mention for females is that it's the external genitalia that are virilized. The internal genitalia, on account of there being no testes to produce anti-Müllerian hormone, internal genitalia are fine. So there are ovaries, there is a uterus, there's fallopian tubes, and there is an upper vagina. So now let's move on to males. What happens to them? So one possibility is that they actually have no symptoms at all. Or you can have increased size or pigmentation of the penis. You can also have precocious puberty or something called a testicular adrenal rest tumor. An adrenal rest tumor is adrenal tissue growing as a tumor in some place other than the adrenal gland, so those can show up in the testes of these individuals. So these were the features based on the hormone deficiencies or excesses. Indeed, there actually can be sort of a spectrum where not everybody has the full presentation. Basically, these get broken down into non-classical, which is the most benign or late onset presenting CAH, and classical, which is an early presenting. Within classical, you can have the full-blown picture where you get salt wasting, or something called simple virilizing, which doesn't have salt wasting. So let's be a little bit more specific about that. So within the classical individuals, you got salt wasting. So these individuals have the genital findings, plus they have decreased aldosterone. So they're salt wasters. They have decreased cortisol. So they have adrenal hyperplasia and problems with glucose. They also have the genital features, which I already mentioned. Let's go on to simple virilizing. So in this case, they have the genital features. They do have decreased cortisol, but their aldosterone is actually okay. So they are not salt wasters, and this would be a safer, more benign form of the disease. Finally, for the non-classical folks, they have cortisol, that's okay. They have aldosterone, that's okay, no abnormalities. And for them, they're going to have late onset sexual characteristics. And this would be something like problems with infertility, problems with ovulation, post-pubertal clitoromegaly, post-pubertal deep voice or increase in muscle mass in females. So it doesn't present in childhood. So the most benign form, also the most late onset form. Molecularly, we've already gone through most of it. Two additional things I want to mention. Number one is that the gene for 21-hydroxylase deficiency is something called CYP21A2. And mutations in this, if they're severe, we can get salt wasting. If they're really not severe, we can get non-classical. And if they're somewhere in between, we can get simple virilizing CAH. So there's a severity spectrum of mutations in CYP21A2. All right, let's move on to how you would make the diagnosis other than clinically. So how you confirm it with laboratory testing. So the most important thing is that you're going to have increased 17-hydroxyprogesterone. This is what the newborn screen tests for. You can also order it from your hospital as a specific laboratory test, and that would either be done with or without ACTH stim test before. And whether or not you give ACTH, you expect this to be high, and there's cutoff values you could look at to confirm the diagnosis of CAH. Next thing you could do is actually look at the gene, and this would be a panel of mutations. You could sequence the whole gene, and you should also look for deletions in the gene, and these are all pretty high sensitivity. Next way you could make the diagnosis, or I guess more specifically, anticipate a diagnosis, is that congenital adrenal hyperplasia is present on some of the preconception carrier screening tests. So if both mom and dad knew that they were carriers and had a child with a clinical picture that sort of looked like this, the odds go up that it is in fact congenital adrenal hyperplasia. Next thing that you'd want to do in any case of ambiguous genitalia, you need to get a karyotype. Is this a 46XY, 46XX, or something else? And to see how that karyotypic sex correlates with what you see on your exam. And the final thing is that you can get levels of other hormones like ACTH. You could get electrolytes, etc. So just other laboratory tests to help you confirm the diagnosis. Next, what's the inheritance and the prevalence? So the inheritance, both for 21-hydroxylase deficiency and the other more rare subtypes that we'll talk about in the part 2 lecture, everything is autosomal recessive. In terms of the prevalence, for the classic form, it's something like 1 in 5,000 to 1 in 10,000. And for non-classical, it's expected to be more prevalent than that. All right, so how do we treat and manage the condition? The great thing is that this is one of the genetic disorders that you can actually do something about, and you can actually do several things about it. So the first thing, you want to get pediatric endocrinology involved. So consult them, set the patient up to see them. In the meantime, it's important to know things about the patient so that you can start to manage them once the diagnosis is made early in infancy. So some things to watch out for. We want to protect them from adrenal insufficiency. So the two things that were insufficient from the adrenal gland were aldosterone and cortisol. So let's give them a mineralocorticoid like aldosterone. The one that you prescribe is called fludrocortisone, and that's only if the patient is sol wasting. Also, you want to give them a glucocorticoid to supplement the cortisol that they're not making, and in this case you'd give something like hydrocortisone. That has the effect of decreasing ACTH, of decreasing hyperplasia, of decreasing hyperstimulation, and decreasing, as a result, androgens. Keep in mind that hydrocortisone has not only glucocorticoid but also mineralocorticoid activity, so it's a really good option to give in patients who are sol wasters. Next thing you want to do, in addition to just protecting from baseline adrenal insufficiency, is avoid a salt wasting crisis. Salt wasting crisis is something that can be fatal in these patients and happens on account of some sort of stress. So an illness or a surgery, some time in which these hormones would normally be upregulated to compensate, but in patients with CAH that doesn't happen. So anytime you have an illness or a surgery, you want to increase the dose or give an extra dose of your glucocorticoid. Also, what you want to do is you can give IV fluids, you can give sodium to tank the person up on sodium and volume, and also some dextrose on account of the fact that their cortisol is not working as it should. Final thing to mention would be surgery or sex assignment. In a patient who looks in between sexes, genital-wise, we call that ambiguous genitalia. And what people have done in the past and currently is to try to think about, number one, what sex is the person? And it turns out the more that we think about this, the more complex of a question it is. Are we talking chromosomally? Are we talking genitally? Are we talking how the person feels? So the identity of the person, well, in most cases this is an infant, we don't know and we won't know for a long time. So doing something that you can't undo, meaning surgery, or raising the child as either a boy or a girl, is something that really does take a lot of consideration. And I think as a field, a whole lot of people have thought about in order to have the best outcome for the patient. And I would expect that as more research is done and as we think about it even more, what we currently do may someday seem old-fashioned, but hopefully at any one point in history, we're doing what's best for the patient. In terms of the surgeries, one aspect that's a little bit more straightforward is if you have a karyotypic female, so 46XX, who looks genitally almost female, but has something, for example, like a stenosed vagina or increased erectile tissue around the clitoris, those are things that surgically you can potentially anticipate that the patient would eventually want to have done, so you do it in infancy, in order for fertility to be as normal as possible in the future. But as I mentioned, things tend to progress over time in various fields. This is one where I expect that what I'm saying now will actually probably be outdated in the near future. The important thing is just to be educated and think about things, not only now, but what things might be like for the patient in the future. Final section, some references. There's a textbook called Clinical Genomics that's edited by Murray et al. That's pretty good. And then, as usual, Gene Reviews has an excellent article about 21-hydroxylase deficiency. I hope you learned a lot about the basics of CAH, specifically 21-hydroxylase deficiency. And stay tuned for part 2 if you want an advanced treatment of CAH, as well as learning about the other enzyme deficiencies that can result in CAH. Thank you so much for watching. If you have any comments, questions, or you would like to contribute a video, email me at quickmedicalgenetics@gmail.com. Thanks!